So we're now moving on to de-prescribing in the last 25 minutes. Okay, all go good. Okay, so this is challenging for you because I really want you to do it, and it's going to be hard because you've got resistance, somebody else prescribed it, but all of us should be looking at polypharmacy and de-prescribing at any time in life. It is not just for palliative care. It is when you're prescribing a new medicine, what else are they taking? Do they need to have all these medicines or not? Okay? So what we're trying to do is to find out, there's a lady that came into one of my nursing homes I was at yesterday, and they said, she's no end of problems. She's 145 kilos and she's taking 25 medicines. We haven't yet done a review on her, and she's taking up so much staff time because she's calling out in pain all the time. So it really is. And I said, well, we've got to stop some. Yes, but she's dependent on them. She wants them. So that is a hard thing. You've got to have buy-in from your person as well. So we talk about the weaning of multiple medicines, and it's like everything. It's go slow, one at a time. You don't go and stop all medicines. You stop them all and end of palliative care, they say, well, I haven't got long to go, have I? But we should be constantly reassessing and going through. We're using too many medicines. It's costing the PBS too much. We can't afford it. We can't afford all your SAS ones. They're Section 100. They're just getting too expensive. We can't afford all the Keytrudas that we're having. So we've got to watch what's going on, and we've got to try and reduce the use. We've got people spending more on complementary medicines than they are on conventional medicines as well. It's a huge marketing campaign. Fish oil, omega-3, multivitamins, calcium, glucosamine, CoQ10, very little evidence for most of those ones. Okay, calcium, we're better to have it in our diet if we can. If we can't get it in our diet, we might need to supplement as well. So we've got the Complementary Medicines Association, and they're saying more than 2/3 of Australians are using complementary medicines. Okay, now amongst you, there's probably, I'm taking one that's still classified as a complementary medicine because I've got to take vitamin D. Okay, it's sort of moving to mainline, but it's still dubious how good it should be. But I can't convert the vitamin D from the sun, so I've got to have it. So that is a growth area. It's absolutely major as well, and the multivitamins with it. If we look at our prescription counts, and this is the number of prescriptions, look here at the top here. You've got fluticasone, you've got the statins, and then you've got paracetamol. This was of older figures on this one. Paracetamol no longer on the PBS, but still is the most frequently prescribed drugs. You've got your pantoprazole, you've got metformin, and you've got your serotype. So stacks of prescription counts there. So chronic diseases are major, and they're costing us a lot of money, but we've got to think about which ones do we really need. People have got comorbidities, they're living longer with it as well. So if we look at a snapshot of people over age 50, and this is from a study at the University of Melbourne, 87% had used more than one medicine of any type in the previous 24 hours. So it's massive. People in Australia rely on their medicines a lot. People in aged care are taking higher rates than actually out in the community. So over 90% of people in the aged care homes are taking more than 5 medicines, and residents consume 10 to 10 doses per day. So they might be having 2 or 3 times a day. So it takes the nurses ages to do the rounds as well. So we've got to look at risk versus benefit, and usually we talk about polypharmacy, which is usually more than 5 medicines per day. But in some cases, if we look at diabetes, we might easily need 5 medicines a day. Because if we've got diabetes control, we need to make sure they've got good hypertension control, which might take 2 or 3 medicines to actually good antihypertensive control. You might have a lipid lowering agent. You might have a triglyceride as well on it. You may or may not have aspirin, and you haven't even started on your antihypoglycemics. And then they've got osteoporosis, then they've got osteoarthritis, and so you're up to 10 or 12 medicines before you even start for these people, used rationally. So here's a little cartoon by one of my ex-PhD students, and I was working with Edwin, and the white, and you can guess what they are. Here she says, well, the white pill lowers my blood pressure, but it makes my legs swell. Oh, so she's on some Lodipine or something like that. The yellow pill lowers the swelling, but causes me to pee. Furosemide, the blue pill stops me from peeing, but it makes me confused. That's my least favourite drug, oxybutynin, in Japan. So the tan pill improves my memory. That could be some Aricept with it, but makes my nose run. The pink pill stops my nose from running but makes me sleepy. She's got some palarin. The orange pill wakes me up but increases my blood pressure. Not sure what that one is. The white pill lowers my blood pressure. But so seriously, it's not without tongue in cheek. This is what they get confused as well. So we have what is called here, this hasn't come through very clearly, but it's off the NPS website, and that is your prescribing cascade. Those of you that are doing exams, get on the NPS website too. That is really good education as well for it. So polypharmacy, we need to look at it. It's not always bad, but we need to look at the risks with it. And in the older people, we've got their bodies not working as well. They can't absorb the medication as well. We've got deficiencies in B12, iron and calcium. Those that are on metformin are likely to have a B12 deficiency. Those that are on proton pumps, theoretically, that's your SOMAC, your low sec, your Nexium, they theoretically could be low in B12 as well, so we need to check those. Then you've got your changes in your volume of distribution, where the body absorbs the drug going round. You've got also your kidneys not working, your liver not working as well, and your kidneys not working as well. So you've got to think about all these changes as people get older. We end up with a statement such as made by Libby Ruffhead over in South Australia of 230,000 unwanted hospital admissions due to medications. So this is where I'm saying we need to be rational before you start typing up your new script. Think, do we need all these? Are there other medications that we could try and get people down off? The ones that cause the most problems are antibacterials. If we look at the latest figures of prescribing, in the top 10 lists, there are 3 antimicrobial agents of most frequently prescribed medicines in Australia: Cephalexin, amoxiclav and amoxicillin. That is the first time that has ever happened with it. Antineoplastics, we're saving people, they're keeping on going longer, but not without their side effects and adverse effects as well. The antithrombotics, and that I would include the antiplatelets and the anticoagulants. Please get your terminology right. I see a lot of people calling antiplatelet agents when they should be calling them anticoagulants. So your anticoagulants, you've got your intravenous ones, your subcutaneous ones, but your oral ones, you've got your warfarin, which you need to monitor very much their food, and INR, and then you've got your new DOACs, which are called novel oral anticoagulants, Apixaban, rivaroxaban and dabigatran. So they are still causing a lot of problems with it, but they are life-saving as well. All your cardiac therapy, there's big problems with it. Diuretics, NSAIDs, which are not the most popular medications, used in short bursts, fine, but only short bursts because they have the GI effects, although you can protect those with a PPI, but you've also got your effect on your kidneys, and you've got your effect on your blood pressure, and you've got sudden stroke and sudden death. I haven't mentioned triple whammy. If you don't know what triple whammy is, you should know it with it, and that is when somebody decides to take a non-steroidal and they're already taking an ACE inhibitor and a diuretic with it. And I had a case 2 weeks ago with a lovely lady who I used to see in a pharmacy years ago, and I was delighted to go and do a home visit for her. And she had a problem with her feet. Her second toe was right over the top of her big toe, but somehow she had shoes wrapping around it. But with that, she had dropped arches, and she had huge feet problems with pain. And she just changed from one doctor, who I knew, to another new doctor. And the other doctor I knew, I thought he was getting a bit past it, but he had actually told her to go to the supermarket and get some Nurofen and take it 2 to 3 times a day. And she was on candesartan and a high dose of a fluid tablet with it, a diuretic. And when we had looked at her bloods, her renal function was right down. And she'd gone to a new doctor because it was closer and it's easier to get to her. And she told me this, and she said, "Your face looks the same as the doctor I've just been to." I said, "I can't believe that Dr. X told you to do that." And he said, "Yes, the other doctor said, is he a very old doctor?" I said, "Well, I think he's probably about the same age as I am, but it really wasn't a good thought." And her renal function was just right down. It had been quite stable. It was down to about 38 mils per minute. And I said, she wouldn't have had a drink in the morning. And on top of that, there's a great story. She had diabetes dietary controlled. And her HbA1c was 5.6%, good, but her fasting blood glucose was about 9. And I thought, what is going on? Okay, so after the hour, which it might have been a bit more than an hour with her because she was very chatty and lovely, she said, well, since her husband had died, she goes to bed with a book and a packet of the Dutch cinnamon biscuits. And so there she is, eating her packet of biscuits, eating her and reading her book, and of course she goes off to have a fasting blood. And what's happening? It's like glucose is high, but she's active the rest of the time, which is why HbA1c was okay. So we worked it out. So those are the things that I find out in my travels. But the important part was not thinking about saying going and getting a non-steroidal. The other one I nearly fell in myself is not thinking about somebody with oral thrush and say, oh, just go and get some Dactara and oral gel. It's been a death from somebody on warfarin on that. And I nearly made that mistake with somebody who was just going out the door and he said, I don't like these amphotericin. And I said, oh, you should get some Dactara. And I said, oh no, you're on warfarin. You know, and I was up to 9 and she ended up in Royal Melbourne and she had a cerebral hemorrhage. Because you get huge absorption from topical miconazole gel. Okay, and then says opioids and psychotropic. So time is getting away from us, so we better stop chatting away so much. So de-prescribing is basically those that have got no benefit, cause harm, the indication is no longer there, and they no longer fit with the goals of care for that person. Okay, so considering to stop them should occur at any time, not just at end of life, depending on patient needs. Now, one of the challenges I have is stopping sleeping tablets. Now, sleeping tablets to me increase their risk of falls and decrease their cognition. But mum wants to stay in her own home. So the fact that she wants to stay in her own home means I've got a bit of a chance of trying to wean her off it. You do not stop them suddenly. If you're on 2 temazepam a night and have been for years, she's going to be absolutely dependent on her temazepam. So she's got to be weaned off very slowly, like 2 tonight, 1 3/4 the next night, 1 3/4, 1 3/4, 1 3/4, 1 3/4, 1 1/2, 1 3/4, 1 1/2. And we go down very gradually, and she's got to be wanting to do it, because if she doesn't, we won't get anywhere. We've got to have other strategies to help her sleep as well. We've got to look at whether, if she's got depression, whether she's actually responding to her antidepressants as well, whether she's got pain, whether she's got constipation, what else is going on in her life, because often it's other worries that they're taking to bed with them. So it's very hard and very challenging to get people off them. So, and prescribers are very, very reluctant if they didn't start them. If it's been started by the cardiologist or been started by the endocrinologist, we might need to refer back to them and with the needs of that person, the care plan for that person. So, as I say, it should be considered as part of a regular medication review where preventative treatment's no longer appropriate. She's bedbound now. Is it really sensible that she still stays on her Actinol or her bisphosphonate? Does she really need to? If she really does, can we change her over to maybe some denosumab, where she only has a subcutaneous injection every 6 months, which is going to reduce her pill burden as well. Is she having lots of falls? Should she be on some warfarin? Should she be on Xarelto, rivaroxaban if she's at home on her own and she hasn't got an alarm and she's falling over all the time? I'd have to say we need to really assess this very carefully. We need to have some OTs in, we need to have some physios to help with balance training, we need the collaborative approach as well. If they've got delirium, which comes on suddenly, we need to say, is this a drug-induced cause, or is it a UTI, or is it all the 10,000 other causes of delirium? If they're getting into cognitive impairment, we've really got to rationalise their medication, as we do at end of life. Those of you working at end of life are well familiar with that. So we're seeing there's been a large use of calcium and vitamin D, and isn't it better to actually have cheese and biscuits, or some yogurt, okay, some dairy products, or some sardines, or salmon? They love sardines, you know, and think about other methods of getting calcium up in the diet. If you are giving calcium, it's best given at night, after the evening meal, when the acid is at its highest, because calcium carbonate needs an acid environment. If you're taking it in the morning, caltrate in the morning with some thyroxine, your thyroxine will be complex with it and you won't be getting the full effect of the thyroxine, also the digoxin. So best at night. If you're giving 2, you go 1 in the morning and 1 at night, but separate it from some of those other medications. It might be 1 at lunchtime and 1 at night. If you're on a proton pump inhibitor, you might be better to have a calcium citrate, which is less affected by the acidity, but you need to have 2 of those. So calcium's not just straightforward, and we also need to look at coronary calcium build-up. Have you done much with the coronary calcium? What are your specialists on about coronary calcium, build-up of calcium in the coronary arteries?
Do you mean prescribing for it?
No, just actually checking, see the levels.
Well, we look at family history first, and we look at risk factors.
Mm.
profile. And then if they think they're high risk, we'll send them off for a CTA. So
Yeah. Certainly it's something to be taken into account. There were a few scare papers. There was one published by a chap in Auckland University, New Zealand, Mark Boland, but the doses were much higher of calcium than what we're using here. But nonetheless, the general thing is try to get 1,000 to 1,200 milligrams in the postmenopausal lady or the older gentleman, but preferably by diet. So have a look at their, get off to the dietitian as well. Vitamin D supplementation is still a bit debatable. How much use is it? We've all gone overboard on it, and the government are complaining about the extra cost of the pathology testing of the 25-OHD. So we need to look at our risk factors with people. I'm still wanting people to be, above the 70, 75 at this stage, but I'm not convinced that it's got all the thousands of benefits that some of the alternative practitioners will have research papers around. So osteoporosis medications, we need to think how long they need to be on, what is their bone mineral density, what are their risk factors, what else can we do. Lipid-lowering agents, do we initiate somebody on a statin when they're 85, 90 in a nursing home? We don't. Do we take them off it? And that is debatable, because if a cardiologist has started it and then the GP gets challenged and I come along and say, look, I think we should stop that, and they say, yes, but if they stroke out the next week, I'm going to have the family suing me. So we've got to be very careful if we do want to go down on this. I used to like doing liver function tests, but they're no longer routinely recommended, so we need to have some symptoms of some muscle pain or something. But if they've got abnormal liver function tests, you've got a better case for it. But certainly I don't like to see the higher doses of the agents such as simvastatin, 80 milligram used in the older person. You're far more likely to get myositis and myopathy and even rhabdomyolysis from that. So you're getting 80% of the effect from the lower doses. So get your doses low with that, at least with it. 1 in 10 people will get muscle aches and pains from statins. So it's not to be taken lightly with it. The antihypertensive treatments, we need to think about what we're trying to do, what we're aiming at, and their risk factors, their absolute risk. And the same with all the antiplatelets and anticoagulants. So how long do they need to be on it is always debatable. And are they having falls? We need to think about if they're having falls, is it because we've got the blood pressure too low? Is it because of too much oxazepam or diazepam or temazepam, so on? What else actually is causing the falls? So terminal illness, we need to think about what do they really need at this stage and go off very slowly, otherwise the family go into shock as well. Focusing on end of life and respecting patient choices. Everyone needs their advanced care planning, so that is really important with it. So it's talking to the patient if they're able to, or talking to the family as well. So start slowly, develop a plan, get everyone on side, and then you're not going to have the same problems. But remembering within families as we move towards end of life that they've got different agendas. That the daughter has been with the mum for ages, she knows that mum has said, how long do I have to wait, etc. And the son, who hasn't been speaking, has now come back and he's trying to make up on the mothering that he didn't get for years because he'd rejected her. And you have all this family disconnect. You've all seen it. So that gets very, very difficult with the different agendas and inappropriate expectations. So it's again talking and documenting what happened at the family meetings, and that's where you're excellent at doing that sort of stuff. I'm a very odd pharmacist because most of the time I like non-drug methods when we can. So for sleep at night, I'm very happy to give them rolled oats in a nursing home at midnight, or a sandwich and a warm drink or something, rather than give them a sleeping tablet. But you've got to have it easy for those poor night staff who run off their legs trying to do everything with it. For constipation, I will use kiwi fruit, being a good New Zealander, and or pears with the skin on, pureed, and just looking back to the diet, what's happening in the kitchen, what can we do. With BPSD, the TGA have recommended we don't use agents such as risperidone or haloperidol for more than 3 months at a time because of the risk of sudden death due to prolongation of QT interval. So we've got to come up with strategies for the staff and the aged care homes to manage, or for the carer who's dealing with that person at home. And that is challenging. It's going back on their life history, finding out what we can do to re-engage with that person. And they go through stages, but just sedating them is not a way to go. I'm actually one of the writers of the review of the RACGP handbook and silver book in aged care, and one of the first things that we came up with our case conferencing was one of the geriatricians saying that he's calling although the PRN use of risperidone as chemical sedation. So he hasn't used the word restraint, and that even gets the accreditors more, but it really is because what you're doing when you're adding on a PRN dose of, say, risperidone or any of the antipsychotics, we see a lot of quetiapine being used, you're not getting the long-term benefits of an antipsychotic. All you're getting is the adverse effect of the sedation. So you're just sedating them, and you might just as well use any other sedative that hasn't got the high risk. So I would prefer that you used a very low dose of oxazepam if all else had failed. By all else, I mean taking them outside in a wheelchair and getting the family to come in and take them for a walk around the streets, taking them out for a cup of coffee, getting a movie on, or doing other things. But we need more staffing. That's the big thing. And the same with analgesia. If we gave you a talk on analgesia, it's non-drug things. It's physio. It's looking at massage. It's looking at things other than increasing the dose of the opioid in most cases. I mean, certainly we have some extreme pain, but things we do have to do. So it's non-pharmacological. So we've got criteria, and if we look at the Beers criteria adopted, those are the ones that I particularly like to highlight as not being a good idea, that I wouldn't want you to be prescribing for older people without a lot of care. And that's any of the tricyclics, amitriptyline, even nortriptyline or imipramine or dothapine or doxepin with it, are concerned with it. Amiodarone is useful and can be used, but with very close monitoring, because it's probably the only one of the antiarrhythmics that we use a lot actually out in the community. We need to monitor thyroid function, we need to watch for pulmonary fibrosis, we need to watch for their liver function tests turning grey, their susceptibility to sun, and so on. So useful, and we need to look at what's actually happening, see whether the dose, because it's got a very long half-life, is the dose too high for that person. Any other comments on amiodarone, Karen?
Long QT syndrome is the other thing I see.
Yeah,
that one,
that's huge. And you add some erythromycin to it, and you prescribe some erythromycin, even some clarithromycin, as a nurse practitioner, and you think they're on amiodarone, you can actually just have enough of that to prolong that QT interval and have a very nasty effect with it. So I say caution. Antihistamine, certainly not the first generation, and only rare would you use the second generation. Benzos, really caution before you're doing those. Diuretics basically gone. Fluoxetine's got a very long half-life and not suitable in the older person. Methyl-dopa makes them depressed as well, and all the NSAIDs were mentioned. Nitrofurantoin is number 3 for acute urinary tract infections, but for preventative, it's gone off now because of the peripheral neuropathy it can cause in older people, and also again a pulmonary fibrosis. So you're better with your cefalexin or your trimethoprim with that one. And oxybutynin, if they're classified as incontinent, then why are you giving another anticholinergic agent? So time's got away on us, so we've got the last couple of minutes, and I'd just like to highlight anticholinergic agents. Those are the ones that dry you up, but they add it together, and they make them confused, and you think your patient's got dementia until you take them off it, and they cause all these nasty things, the confusion, the delirium, the dry mouth, the constipation, but you might be using them for urinary retention, but you've really got to think, are the risks worse than the benefits, and they can cause cardiovascular arrhythmias. I've listed all the ones there that you need to watch out for, including all my llamas over there, because they're going to add to the use of the little dose of amitriptyline that they've had at ages to help them sleep, and together with the oxybutynin for their continence. So their kidneys go down, so we've got to think about the drugs that are renally cleared. That's all on your notes to refer to. We're not going to talk at Mrs. Boyle today, she's going to have to wait. What I've got is, and you can have a look at these in your own time, I've got some classes of medications for consideration of de-prescribing. Now the notes that are the best ones around is a website in Tasmania on the Primary Health Network, which is a guide to de-prescribing. We're eventually going to get something in the Silver Book, and the NHMRC will be producing this, but this one you can just do De-Prescribing Tasmania and you'll be able to get it up. So it's under Consultant Pharmacy Services. They got a grant from the Primary Health Networks. Now this one here is about 11 or 12 pages of a summary that GPs love. You might like more detailed because each one of these classes has got 5 pages about it. And any of you that are doing your exams at present will find it a really smart way to get up to speed on the main classes of drugs. So it goes through all the ones from allopurinol to de-prescribing proton pump inhibitors, which need to go slowly, antihypertensive medications, bisphosphonates, cholinesterase inhibitors, and so on. Talks about what to watch for when you're de-prescribing. So that's all there. So what we're really on about is shared decision making. Don't do it on your own. Bring in other people into it. Get your case for what you're going to do. Get a plan. Go slow. Do one at a time. Go very slowly. Unless it's at end of life, you undertake it very slowly and under medical supervision with it. You often find that drug interactions can be unmasked as well. So if they've stopped smoking and they're still on diazepam, you'll find that they are so sedated because it stopped the metabolism of the diazepam has changed and the levels will go up. So you've got to look for some of these things. So when you download your notes, you'll get examples of the medications that need care with de-prescribing and how to develop a plan. So I'm sorry I've been rushed at the end, but there's a lot to cover, and I think the benefits of it is that you actually find that people taken off their medicines may actually improve in some cases, which is quite interesting. So we need to really rationalise it, and we need to think about medicines to treat side effects of other medicines. Sometimes less is more beneficial. And here you are out seeing your lady, and she says there's more under the sink. So these are our people, and good luck. I think you're all doing a fantastic job. It's been a pleasure to share some of my experiences with you. Thank you very much.